like to let everyone know the session is being recorded. And we are very privileged today to have Dr. Elsa Wiekers join us. She is the National Director for Psychopharmacology and Somatic Treatments, the Office of Mental Health and Suicide Prevention in the United States Department of Veterans Affairs. Dr. Wiekers is an Associate Professor of Psychiatry at the University of California, San Francisco. And at this point, I will turn it over to Dr. Wiekers.
Thank you, Jeff, and welcome everyone. I'm going to give it a second for my slides to pull up. It's a pleasure to be here with you and to be talking a little bit about the work we've been doing at the Veterans Health Administration related to prescribing safety and the new directions we're heading towards with a stimulant safety initiative in the coming years. Thanks for joining. Just before I go any further, is my audio coming through clearly for folks? Okay. All right, I'm going to proceed then. I have no disclosures. I'm 100% salaried and employed by the Office of Mental Health and Suicide Prevention. Nothing else about the presentation today to disclose other than while here on behalf of VA, I'm not officially representing VA, but that's just sort of my usual hand waving when I do presentations. So learning objectives for today, I want to talk a little bit, just for those of you that may not be familiar with the size scope of the Veterans Health Administration, so you get a sense of the size of the system that we're talking about these prescribing safety efforts in. Talk a little bit about some of our previous success that we've had with opioid and psychotropic medication safety initiatives, explain why it's important to focus our attention on stimulants now, which I think I'm probably preaching to the choir here at a Psychostimulant Symposium. I'm sure all of you know this part, so I'll kind of zoom through that section of the talk a little bit quicker, but I'll talk about some of the key challenges to the work we're about to launch at VA with our Stimulant Safety Initiative and some of the next steps we're taking to prepare for that. First, the Veterans Health Administration overview, and actually if we could pull up some poll questions, I'd be really, if we can drop those in now, if I can have some help with that. Before we talk about, or is there a way to, oops, sorry, there we go, thank you. I'm curious, those of you in the audience, how many of you have served in the military? Let's see if we have any veterans in our group today. All right, well, thank you to the veteran who is with us today for your service. Can we take the next question in about how often do you work with veterans? So next question, just get a sense from those of you that are joining us this morning, how often do you work with veterans in the services that you're providing currently? And that question is going to pop up in just a second.
Maybe once I figure out how to go over.
All right. Well,
maybe it will
I'm
once
going to
I
go
figure
ahead
out
and proceed.
how to move that over.
I'm not sure if any of you are affiliated with the Veterans Health Administration, but what our goal at VHA is to honor our veterans by providing exceptional health care that improves both health and well-being. We have 4 statutory missions. It's in addition to healthcare, it's also education and training, and research and emergency management. So we're part of the federal emergency response. You can go ahead and drop, see we've got the poll open while I continue to talk about VHA. I'd love to see how often you're interacting with veterans in the services that you provide. So the VA is the Veterans Health Administration is the largest integrated health system in the country, possibly the world, depending on how you count things in NHS. We have 18 different VISNs, or Veteran Integrated Service Networks. You can think of them as regions. So we kind of have regional system within the large national system of healthcare. And we have over 1,200 different sites of care. You can see listed on this slide all the different types of care sites that we have. In addition to what I think people typically think of, the medical centers, we also have standalone community living centers, which are VA versions of nursing homes. We have healthcare centers, community-based outpatient clinics that are both primary care focused and specialty focused. We have several standalone residential and domiciliary units as well, and other outpatient services, again, totaling over 1,200 sites of care. So it's an enormous system of care, and we provide care for millions and millions of veterans and across the country. So we have over 9 million enrollees in fiscal year 18, 6.3 million patients, actual users of the system in fiscal year 18, with over 85 million outpatient visits, over 500,000 hospital discharges, and an enormous amount of telehealth that we do, even more so this past year with COVID, as we've all, I think, experienced. But we were doing a lot of telehealth even before that. And I'll just note that mental health services, which is inclusive of substance use disorder treatment in the VA, mental health services is actually one of the largest services that we provide for our veterans. In fiscal year 19, 1.75 million veterans received a mental health service of some sort. That's approximately 29% of all VHA users in 2019. So just shy of 1/3 of all veterans who use and seek care at VHA in some capacity are also receiving a mental health service. So mental health, again, inclusive of substance use disorder treatment, is one of the biggest pieces of the services we provide to our veterans. So VHA has been working for many years now on safe use of opioids and psychotropic medications, and that's what's leading us down the path towards our coming efforts around stimulant safety. And so I wanted to share some of that success with you before we talk a little bit about what we're going to be doing next. So the success of our previous prescribing safety initiatives really is based on close collaboration across multiple stakeholders within the system, both at a local level, at that VISN or regional level, and then at the national level in VA Central Office where I work. And that's been close partnership between mental health, primary care, pain, and pharmacy that has really led to the success that I'm about to share with you. So the VA Opioid Safety Initiative launched 8 years ago, piloted in 2012, and then was expanded to national rollout in fiscal year 2013. The goals of the Opioid Safety Initiative at VA were to reduce the over-reliance on opioid analgesics for pain management and to ensure safe and effective use of opioid therapy when it was clinically indicated. It was really a comprehensive strategy that included provider education, which was in large part done by my colleagues in academic detailing, which I'll speak about in a little more detail in a moment. And then also really improving our access to non-pharmacological modalities for treating chronic pain. One of the keys to the OSI was the OSI dashboard. So as you may be aware, the VA has an integrated electronic health record, so it allows us to have really robust access to almost real-time data for all of our patients across the system. So we've created a lot of really robust dashboard tools and informatics tools, the OSI dashboard being one, that really provides kind of real-time feedback to stakeholders across all of our facilities to help them identify patients where a possible change in prescribing would be indicated. The OSI and efforts to reduce over-reliance on opioids was part of and kind of built on top of what was already taking place in VA, which was stepped care, a model for pain, which was established back in 2009. You can see in the figure on this slide the kind of idea of building first on patient education and self-care, then moving up into treating pain in primary care, and if that's not successful, moving into a secondary consultation, and then at the top are interdisciplinary pain centers. And so we've worked really hard across the VA to improve the access to these each of these different steps along the way. As part of our opioid safety initiative, we, in addition to focusing on opioid prescribing, we also focused on risk mitigation strategies. What you can see here, the chart on the top actually shows over time. So it's the x-axis is time. You can see an increase in the number of patients on long-term opioid therapy who had received an annual urine drug screen. That's the dark line at the top. And actually, let's see if I can get my arrow to work. Yep. So that is. So this is our increase over time of patients who have received UDS, and then this is the tracking over time the percent of patients on long-term opioid therapy who have received assigned informed consent. And then more recently, you can see this curve here talking about opioid prescribing patients who have received an annual PDMP check. So these are some of the risk mitigating strategies that we've focused on, and you can see the improvement that we've experienced over time. A lot of that due in part to academic detailing. You can see the number of academic detailing outreach visits, and again, I'm going to talk about that in a minute. And there are 22,000 unique staff members across the system who have interacted with an academic detailer specifically about opioid safety. Also, you can see that we have 68% of our sites that now have all four aspects of what is considered an interdisciplinary pain team, which is pain management, behavioral therapy, rehab medicine, and access to both assessment and treatment for opioid use disorder. And then again, just showing some of the success in our risk mitigation. You can see the top left here is showing over time, and I'll pull back out my little arrow. This one over here is showing the total decrease in veterans receiving an opioid. So it was a 56% decrease from fiscal year 12 to fiscal year 19. We had an 83% decrease in opioid benzo co-prescribing, 77% decrease in high-dose opioid prescribing. So that's greater than 50 methadone or morphine equivalent daily dose. And then this is the huge success actually that we've had with our naloxone distribution. So over 217,000 veterans receiving a naloxone kit, and we've had over 1,000 reported reversals, so lives saved. And to speak to that a little bit more, our opioid overdose education and naloxone distribution, or OEND program, really focusing both on providing patient education on how to prevent and recognize and respond to opioid overdose, while also providing patients with naloxone and training them on, as well as training caregivers and family members of those patients on how to safely and appropriately administer naloxone. We've had, and the patients we've targeted there have been those with opioid use disorder and also those who are prescribed long-term opioid therapy. We were able to eliminate copays on naloxone and its training, so this is essentially no cost for veterans and for at-risk patients. They receive these kits and the training for free. And the most recent updated, this is hot off the presses, November of 2020 data, we have 260,000 veterans who have been dispensed naloxone, and we've had over 1,500 reported overdose reversals across the system since the OEND program launched. This is one of our biggest successes, I think, and one of the biggest impacts of our efforts with the Opioid Safety Initiative in recent years. Also wanted to add that the VA has developed stepped care for substance use disorder, kind of similar to what we do stepped care for pain. We do stepped care for substance use disorder as well. So the foundation of that is, again, kind of self-management, mutual help groups, skills applications, and many mobile apps that we have developed and deployed. The first level is management in a non-SUD specialty care, so that's either with general mental health, primary care, or in pain clinic, and then stepping up when needed to actual SUD specialty care. And we've increased and targeted specifically the ability of primary care providers and general mental health providers, as well as some of our pain providers, to be buprenorphine prescribers. And this has been a big effort in recent years with the SCOUT program that has really driven the education of general providers, in other words, not addiction specialists or substance use disorder specialists, but the primary care and general mental health providers to be prescribers of buprenorphine. So I'm going to pivot now to talk a little bit about the efforts across VA for psychotropic drug safety, and that's the PDSI, the Psychotropic Drug Safety Initiative. This is a program I've been leading since 2013, and the Veterans Health Administration sees this as a sort of a national quality improvement program. So it really focuses on improving practices for prescribing of psychotropic medications and ensuring that our veterans are receiving those mental health treatments based on evidence and clinical practice standards. So the key components of the PDSI program, again, which launched right about the same time that the OSI program launched, is that we create nationally identified priorities and then allow facilities to choose what area within that national identified priority set they want to focus on. So we give them a menu of options, so to speak, of areas of prescribing that they can work on with their local QI, and then we support that at a national level with quality metrics. So we have 39 different quality metrics now that we track that are related to prescribing of mental health psychopharm. We also have a dashboard. I'm going to show you a screenshot of it in a moment, which is a clinical decision support tool and helps to identify patients who might be good opportunities for change or improvement in prescribing. We have technical assistance we provide, as well as QI strategic implementation help, and then we run a robust learning collaborative and have a lot of other educational opportunities. This is a quick screenshot of our PDSI dashboard. You can see that what we have here are a list of several different metrics. This is kind of the facility would be listed here, and then these are some of our current efforts, which are focused on benzo reduction in high-risk populations. So you can see the different metric names. You can see what direction ideally you'd like to see the metric go, down or up. You can see these are spark lines that show the last 4 quarters or 1 year worth of data and what's been happening at this facility with the score. You can see the actual facility score here. Gold star means you're doing better than the national score, which is listed here. And then this is really where the QI happens, and that is in these actionable patient lists. So we have an outpatient, an inpatient actionable patient list. The outpatient actionable patient list is, these are all outpatient metrics. So that's why you don't see any inpatients. But in previous initiatives, we've had inpatients as well. So these are, you can see at this facility, we've got 456 veterans as of yesterday, if we had just run this data on our live dashboard. As of yesterday, 456 veterans over the age of 65 for receiving a benzo prescription. And if I were to click on that number right there, it's a hyperlink, and it'll take me to this screen where you actually will see a drill down on patient information. This shows you patient name and some background information, all the different metrics that they have registered on or been flagged on, a bunch of different clinical details, including whether or not they've had their PDMP check recently, whether they have multiple benzo prescriptions, different diagnoses that they have that are mental health diagnoses. They'll be all listed here. And then a variety of kind of risk factors, so things like stimulant prescription, so co-prescribing could be easily identified here, whether they have traumatic brain injury or respiratory disease or dementia. These are other risk factors. And then as you scroll to the right, you then will see the actual medications that have been prescribed, what the adherence is, so that's a medication possession ratio, months they've been on that medication, the prescriber. I identified myself as prescribing all these benzos. I can assure you I do not, because this is my life's passion to try to reduce unnecessary benzo use, but to protect others, I have labeled myself as the primary care doctor giving these prescriptions away. And then we have, this is also really helpful, we have lots of information pulled in on most recent and upcoming visits, both primary care, mental health, and other. So you can see if there's a point of intervention. So for example, this patient has a lab visit, they're scheduled for the lab coming up, or this patient is going to see their primary care. You can see who their assigned providers are as well. So this allows the teams on the ground doing quality improvement, trying to change prescribing. This gives them real-time actionable data. And so this is, a lot of our dashboards look similar to this. We're really excited and proud of these tools. People have been using them now for over 6 years, and it really is kind of the jewel kind of sitting at the top of the crown of all these prescribing safety efforts. So PDSI has been, as I mentioned, has been going since 2013. You can see the different phases of the program and what our national initiatives have been for each phase. Currently, we're in phase 4, which I've alluded to being reducing benzodiazepine use in high-risk populations. We will be launching in January of 2022 our Stimulant Safety Initiative, and that's why I'm here today, to talk to you about that. But you can see that PDSI has had a great deal of success. I'll highlight, for example, that we reduced polypharmacy, 25% reduction of polypharmacy in veterans with PTSD in phase 1. A lot of phase 2 focused on older veterans, and 10% of all older veterans who received a psychotropic prescription across the VA system had an improvement in prescribing as a result of phase 2, with over 20,000 fewer older veterans receiving a benzodiazepine or a sedative, which was a 25% reduction. And in phase 3, we focused on substance use disorder pharmacotherapy. So over 12,000 more veterans received access to medication-assisted treatment for SUD as a result of phase 3. So we're really proud of the hard work that all of our partners at our local facilities have been doing over the years towards PDSI. We have partnered with our colleagues in academic detailing for much of our education and for a lot of our efforts to implement change across the system. Academic detailing is within the VA is being done through pharmacy benefits management. So these are folks who are trained as clinical pharmacists who then go out and do in-person outreach, although now it's being done often by tele given COVID. But initially it was designed and developed as an in-person outreach. So this is the educator, the academic detailer, sitting down and interacting directly with the prescriber, with that provider, having a conversation with them to understand where are they coming from, why are they prescribing things the way they are, then to modify in real time, once you understand where that person's coming from, to engage them in considering change in prescribing practices. And it really is about bringing the evidence-based information to prescribers and developing relationships. It has been highly successful, and I'll show you a few of both inside and outside VA, and I'll show you a few of the key successes we've had with academic detailing at VA in just a moment. So a session with an academic detailer really aims to identify the gaps in knowledge and what the barriers are to implementation. A lot of the work that academic detailers do is actually based in motivational interviewing techniques, which is, I think, really fascinating as a psychiatrist myself, and being trained in motivational interviewing, the idea of using motivational interviewing with other providers to help them see where they're at, meet them where they're at, and then try to convince them to find move from pre-contemplative to contemplative around changes in their prescribing practices is really an interesting way to frame things, and it's been very successful. It's multifaceted, so it really is about kind of working at a systems level, as well as kind of those individual direct face-to-face provider contacts and educational opportunities. They have an enormous amount, as you can see here, of campaigns that they've developed over the last 5 to 7 years. And you can see several of these in the mental health space, many of these in the mental health space and substance use disorder space, but they are by no means limited to that. They're working as well in COPD and heart failure and headaches and pain and all sorts of different things that they've been working on, HIV treatment. So there's a lot of a robust set of educational resources available through VA academic detailing for providers and for patients as well. Just to show the success that they've had, so when you combine the OAND, that's again the naloxone overdose kits and educations, when you have providers who were exposed to an academic detailer compared to providers who were not exposed to an academic detailer. Those who received academic detailing were 3 to 7 times more likely to prescribe naloxone to their patients. So you can see this is the top bar. You can see that it's a steeper slope and a higher average number of naloxones prescribed per month for those who received academic detailing compared to those who did not. Similarly, the impact on benzodiazepine prescribing in patients with PTSD, the providers who had an interaction with an academic detailer are this dark blue line on the bottom, and those who were not are the red line, relatively unchanged across the top. So again, a high impact and one of the keys to the success in previous prescribing safety initiatives that we've had across VA. So why turn our focus to stimulants now? Well, I think all of you are probably on the same page with me here, but bear with me while I go through what my rationale has been to leadership for why we're doing this. And first, I'll just pause and say when I say stimulants, I'm meaning several things. I'm meaning prescription stimulants, for one, things like, as you can see, the Adderall pill there. But I'm also talking about illicit substances like methamphetamine and cocaine. So we are thinking kind of inclusively of all of these, not just prescribed stimulants, because we recognize there is some relationship between, though actually that's one of the gaps in knowledge is the appreciation for or kind of delineation of what is the connection between people who have used or misused prescription stimulants and how does that correlate to future use with methamphetamine or cocaine. But first, a few words about the increasing use and misuse of prescription stimulants. We've seen a very big rise over the last decade and a half. It's doubled the use of prescription stimulants in the United States. We know that diversion and non-medical use of prescription stimulants is fairly common, especially among the young adult and college-age students. About approximately 5.1 million Americans reported in 2018 that they misused prescription stimulants. So that's about just shy of 2% of the teen and adult population in the US. This is data from within VA. So this is looking at the rise in stimulant prescribing, which is, I'll get my little handy arrow out again, which is our blue line. So this is stimulant prescriptions across VA over time. And then you can see here in the orange line, this is the number of veterans with an ADHD diagnosis. So that has sort of tracked along with, right? But there's, as you notice, there's a gap. So about 80% of VHA users have prescription stimulants have an FDA indication for use. That's largely ADHD diagnosis. There's a little bit of narcolepsy in there. We maybe have a handful of folks with a binge eating disorder being prescribed a stimulant. Those are the FDA indications. But about 20% do not have an FDA indication. So those are some of the folks that are opportunities for improving our prescribing. I think really focus on that 20%, as well as ensuring that the people who are getting it for an FDA indication are getting benefit from it, and that the risks and benefits still lean towards the benefit as opposed towards the risk. So I'll say a few words about methamphetamine, illicit methamphetamine use. So about 1.9 million Americans used methamphetamine in 2018. We know that that has been going up. Treatment admissions involving meth have increased significantly over the past decade, and that's across almost all demographic groups. So there's no, we used to sort of have stereotypes about the type of person who uses meth and the regions of the country where it was a problem. As you can see in the bottom point, bullet point, primary heroin treatment admissions reporting meth use has gone from 1 in 50 to 1 in 8. There's a lot of polysubstance use now, much more commonly seen that folks are using both opioids as well as methamphetamine. And it's across, again, all demographic groups and all regions of the country. So meth really is becoming a national problem, not just a regional problem in recent years. We know that people using meth have a much higher rate of co-occurring substance use and mental illness. And we also know that, as I just alluded to, polysubstance use seems to predate methamphetamine use. So they are using a variety of different substances, and then they come around to finding meth. And so you can see those substances listed here, the variety of different things folks have been using before they started using meth. In terms of cocaine trends, we see about 5.5 million Americans used cocaine in 2018. This has also increased a little bit over the last decade. You can see here, and I'll grab my handy tracker, again, you can see an increase from what was a bit of a drop in the early aughts, and we're back up again now towards the end of this past decade, but really on par about where we were early 2000s. But still, a lot of folks using cocaine, and a serious issue that we need to be concerned with. One of the main reasons, though, I think, and the pressing reason why we need to be thinking about stimulants now is because of the increase in overdose deaths. You can see here in the background, that big dark black line is obviously opioids. But what I've done here is I've pulled out this data from the CDC, and you can see that in the last year, the cocaine and psychostimulant lines have now crossed heroin. So we're having more overdose deaths here in the pink and gray from cocaine and psychostimulants, which includes both meth and prescription stimulants, than we have from heroin, which has now dropped off a little bit. So these have now surpassed heroin in terms of overdose deaths. And a lot of this is opioids playing a big role. So it's the polysubstance use, or it's the fact that sometimes fentanyl can be mixed in with meth and cause unintentional or unwillingly folks are taking things like fentanyl and not realizing it, and that's causing overdose death when using meth. So you can see a big increase in the psychostimulant with any opioid. That's the green line has gone up and has driven that substantially. Here again is some data from within VA, again making the argument to our own leadership why we need to be thinking and paying attention to this stimulant use. You can see the trends in stimulant overdose death among VHA using veterans has really gone up pretty substantially over the last from 2010 to 2017, which is the last year we have death data. So we have, again, you can see the crude rate and adjusted rate going from about 5 to about 13, 14. And you can see a total of nearly 800 overdose deaths in 2017. Again, those, and then looking at that possibly co-prescribing or at least the polysubstance use of stimulant and opioid, those numbers are tracking up as well across that same time period. So hopefully you all are on the same page with me. You agree that stimulants are a big issue of concern and something we should be thinking about and focusing on. I have successfully convinced leadership at VA that this is what we should use as our next national priority for the Psychotropic Drug Safety Initiative. So we're heading in that direction. What are some of our challenges? Well, we know from some data that we evaluated back in 2018 that there's a high amount of co-prescribing, specifically that veterans receiving stimulants are very likely to also have co-prescribed opioids or other sedating psychotropics, kind of the upper downer combo, right? So folks are getting something sedating and then also getting a stimulant, prescribed stimulant. And that really has an increased risk of harm. It's a big concern for us. And how do you really prioritize which medication to taper when you have multiple high-risk agents? This is a big question we have to ask, and something we need to think about and help our frontline providers think about these questions and provide some guidance to them around thinking about when you have multiple agents on board that could cause risk or harm, how do you prioritize which to address first? We also see a change in our veteran population. So we have historically thought of the veteran population as being an older cohort, and it is largely a lot of Vietnam vets and Korean War vets, but we also have 25% of all veterans are under the age of 50. We have a large cohort of people from OIF returning from Iraq, from Iran, from Afghanistan and Iraq. And they are, and many of them are utilizing the GI Bill. So we reinstituted GI Bill in 2009. And since that time, about 800,000 veterans and their families have utilized GI Bill funds to access education. And if we're talking about prescribed stimulants, of course, we think about ADHD. And when we think about people trying to access those educational benefits, some of them are starting to struggle. And it's really difficult to understand whether the struggle in their schoolwork is related to an existing ADHD or maybe an existing ADHD that was never diagnosed as a child, or maybe it was diagnosed as a child, and then it kind of fell out of concern because the structure of military life really helped kind of keep things glued together. And now that they're back in kind of work and family life and trying to get school done, it can be a real challenge, and is posing more challenge to them. Also, many of our veterans who have returned are struggling with PTSD and traumatic brain injury, or depression and substance use disorder, all things that can also impact attention. So really teasing out the right and the accurate and appropriate diagnosis first is one of our big challenges, and making sure we're giving evidence-based treatments for those diagnoses is going to be one of our key challenges. Also, we realize that there's not a lot of evidence and not a lot of guidance around how to de-prescribe stimulants. So when we have people who are taking them, if we determine it's inappropriate and that it's causing risk but not benefit, and we want to stop it, what's the safest and best way to do that? We've got lots of data and lots of clinical experience on how to do this with benzos. We don't, and opioids as well. We don't have a lot of experience and evidence to guide us around how to safely de-prescribe stimulants. And it's unclear what the harms are that would be associated with discontinuation. We also want to be very mindful moving forward that there are no unintended consequences of prescription discontinuation. Specifically, and noted, and something we're thinking carefully about, is ensuring that patients don't start to seek out other potentially illicit sources for stimulants, and also to ensure that we don't worsen symptoms or functioning of patients who'd been receiving it for an FDA indication. So a lot of things to think about as we craft our messaging and our guidance going forward for the stimulant safety initiative. And that brings us to the path ahead. So we really are building on a robust partnership and a lot of resources, as you could see from the first part of the talk, that we've had in place now for over 6 years. A lot of infrastructure between the PDSI program and our partners in academic detailing. A lot of lessons learned from the Opioid Safety Initiative and our previous efforts to address overdose and risk mitigation around overdose deaths. This next step, dealing with stimulant safety, really is a logical progression of the ongoing work we have in the decreasing benzos in high-risk populations and efforts to try to increase access to SUD psychopharm. And we have some existing campaign materials. We have provider and patient education materials, as well as an informatics dashboard that was developed by our academic detailing partners back in 2018. There are several sites and academic detailers that have been using these resources over the last 2 years. And so we feel like now's a great time to take this, buff it up, and package it so that we can have it launched nationally as an initiative. We will be hosting our own Stimulant Safety Summit in February. You can see the dates listed there, so just coming up. Our goal of having our Stimulant Safety Summit is to bring together all of the VA stakeholders, as well as the subject matter experts from both inside and outside VA, to talk about what are our recommendations for developing this initiative, what are the key goals, how do we think about the metrics that we develop, and what strategies for implementation should we follow in order to ensure the greatest success, and ensure that we're helping, not hurting. So again, trying to avoid potential for unintended consequences. This will be a partnership hosted by the PDSI and academic detailing services. So some of those key questions, for example, that we're bringing to our subject matter experts at that summit: how do we best support and ensure accurate diagnoses? And how do we ensure that we have access to evidence-based treatments, both pharmacologic and non-pharmacologic, and identifying where the gaps are within our system so that we can bolster the needed resources to be ready for that. How do we address inappropriate use of prescription stimulants while also minimizing those unintended consequences? And this really speaks to identifying metrics that are developed carefully and thoughtfully, and also our key messaging for our educational products. And then something that I think a lot of us struggle with and have this question, one that we will continue to address moving forward with our clinical initiative, but also I think in partnership with some of our research colleagues, is what's the relationship between prescription stimulants and stimulant use disorder? So having a better understanding of that. So the path ahead is, again, in February, we will be hosting that summit. In the spring, we will be developing and building out our metrics and data tools and the educational materials. We'll take that final kind of packet of information to senior leadership in the summer, and then also sharing it with the field for feedback before we then launch the quality improvement initiative in January of 2022. So we're just about a year ahead of launch with a lot of exciting building to go. And so we're here now, and I'm presenting to you in part so that I can learn and hear from you your own experiences, and so that we can make sure we're doing the best for our veterans and the care that we provide them. Everything that I've just shared with you is the work of a large team of people. You can see our Office of Mental Health and Suicide Prevention leadership team, folks at the 3 different program evaluation centers that support OMHSP, NEPIC, PERC, and SMITREC. Those are the data folks and the program evaluation folks. Our PBM or pharmacy colleagues there on the top right, the team of folks working on OSI and collaborating with us on overdose prevention, and our SUD team as well. So just wanted to make sure everyone gets credit for all the hard work the team has put into this. And I will pause there and see what questions we might have.
Thank you very much. One of the questions that came in is how to withdraw.
Thank you very much. One of the questions that came in is how do withdrawal symptoms vary using stimulants?
Thank you for that question.
Should treatment be different?
That's a really great
which I assume is
question. One that I don't
compared
think,
to
again, this gets to
opioid.
the lack of what I think is clear evidence on how to discontinue prescription stimulants. I think that it's quite possible and quite likely that the withdrawal and the is actually going to be is going to look and be different, and how we address that. I think we're trying to put together the pieces on what it should look like. I don't. That is the short answer, Kathleen. Is I don't have a quick and easy response for you, because I don't think we have the evidence to tell us the right way to do it. I think it's going to look very different than what we do for our alcohol use or opioids or benzo patients. But the best way to do that, we're working to gather the evidence with our own summit, and then reaching out to subject matter experts to really get a better understanding of what we can do to support patients who are potentially in withdrawal as we discontinue use.
The question is, you're beginning this
another question is, you're beginning this in 2021. Is this taking place throughout the Veterans Health Administration system, or just select locations?
I'm wondering if you could type that into the box as well. Sorry. And if other folks have questions, please feel free while Jeff is typing.
Sure.
Also, I saw that many of you in the poll earlier stated that you're working with vets fairly regularly, if not on a daily, a weekly, or monthly basis. So thank you for the care you're providing our veterans. I appreciate it, even though, I'm curious if some of you are actually working at VAs or affiliated with VAs, or if you're providing care in community settings for our veterans. And if you want to comment in the Q&A in the chat, I'd appreciate that, and just knowing a little bit about your own experiences with veterans. Any other questions folks have, feel free to drop them in the Q&A. And Jeff, I'm waiting for your question to pop up. I don't see it yet.
Can you see it yet, Elsa?
I am not seeing it.
Can you see it yet, Elsa?
I see something else, though, that has just, is there any correlation between rising cannabis use and stimulant use? Well, that's interesting. There is, I think there's a lot that's been done recently looking at cannabis use and the increase in cannabis use leading to a variety of other kind of polysubstance use. The specific connection between cannabis and stimulant use, I don't know that I've seen anything looking at that, but it's, I think in general, the increased use of cannabis across the board is being correlated to increased use of lots of other substances. So I would suggest, or I suspect, though I don't have the data in front of me to confirm, that yeah, there is likely a connection between the two. Thanks, Kathleen, for that question.
Yeah, for some reason I'm not able to type into the Q&A.
Yeah, for some reason I'm not able to type into
Let's see
the
a few other
Q&A.
comments here. Let's see from Carolyn. My agency works with veterans who may or may not have legal requirements to meet that pertain to substances, mental health, and or anger management education-based treatment or domestic violence education-based treatment. Awesome. Thanks for sharing what your agency does, Carolyn. So you're, got it. Great. See, Hannah has added something here. I work at a day reporting center, and some of the clients that are mandated here are veterans and closely work with VA hospital in Lebanon. Oh, I know some folks there in Lebanon, both folks who live in the area, friends, and also folks who work at that VA. So thank you for your work, Hannah, with that team there in Lebanon at the VA. We'll see if there's any other questions or comments folks want to make. Thanks, Heather. I see she's adding here that she's worked in both short and long-term residential treatment and currently in a halfway house with males, recently seeing more veterans in the past few years. Yep. And I saw, whoops, I saw something, but it just covered over. If we think, there we go, thank you. Noticing an increase in, so from Carolyn, noticed an increase in prescription medical marijuana to treat PTSD. Yes, and have you noticed a similar increase? Do I have concerns related to the potential concerns related to brain function, i.e. gray matter and activity between right and left hemisphere activity? Well, I can say with I can say that the VA and Office of Mental Health and Suicide Prevention does not support medical marijuana as a treatment for PTSD. They're definitely in the states where medical marijuana has been legalized. Many of them have PTSD as one of the diagnoses for that prescription, so to speak, of medical marijuana. I think that is ill-advised. That is my personal professional opinion. But I think you could get just about anyone in VA central office and dealing with substance use disorders, treatment, and mental health to say about the same. So we've seen a lot of increase in the states where it has been legalized among patients with PTSD. And I do have concerns for all the things that you mentioned in your comment and your question. I also have concerns that, in addition, kind of going back to the earlier comment and question, I have concerns that the medical, even if it's medical marijuana use, that it is potentially going to lead to additional substance use of other substances, and that perhaps stimulants or opioids or other things down the road later on. So I do have concerns. We have lots of other evidence-based treatments for PTSD, both pharmacologic and non-pharmacologic, that I think have much greater efficacy and evidence to support their use than the use of medical marijuana. I see a question from Jessica. Is this new phase 5 that the VA is hoping to launch in January? So it's actually January 2022. I know I'm excited and hope it would start next year, but because of COVID, we've had to push things back a little bit. We had to hit the pause button on our planning. So it's actually a year from now in January 2022. It's going to be at every VA at once, correct? So this will be, the PDSI program is active at all sites as we speak, and has been running since 2013. The current focus of your local VA is right now on reduction of benzodiazepine in high-risk populations. They will, and they have a particular target that they're working on, and they'll continue working on that for this calendar year 2021 while we roll out the Stimulant Safety Initiative and work to develop it. So then January of 2022, every VA across the country will have chosen a new stimulant safety kind of priority target. So efforts will be underway, and many sites actually start a little ahead of the game since we're launching it and people know about it. Some folks will get started early. So it's quite possible that one of the medical centers there in Pennsylvania will actually start to dig into stimulant safety and safe prescribing of prescription stimulants in this coming calendar year before formally the national initiative launches in January of 2022. So what is recommended for ADHD and how does Adderall work? Why is it not widely prescribed? So that's a great question, Kathleen. I think one of the challenges with the ADHD diagnosis in adult populations is trying to determine the best way to kind of confirm that diagnosis, right? I think that historically ADHD has been thought of as a disease, an illness or a disorder of childhood, largely because we thought about the dysfunction in the educational setting, and it's diagnosing in a child requires impairment in function in multiple settings, but it's school, home, and social, right? It sometimes is difficult to figure out how to ascertain impairment in function in an adult without necessarily having to have a detailed conversation with their employer, and a lot of people don't want their employer to know that they think they have a problem, right? So it's a challenge to diagnose when you are potentially only speaking to one source of information, which is the patient themselves, who has to self-report the functional deficits they're experiencing in multiple spheres of their life. And then in terms of how psychostimulants work for treatment of ADHD, that is actually a rather lengthy talk that is its own hour-long talk separately. Why is it not widely prescribed? I don't know that it's not widely prescribed. I think it is in certain populations. It certainly is used a lot, or has been prescribed historically a lot in the adolescent and young adult population. I think part of the concern is that it has been misused and diverted by that population, and that has led to some reluctance or hesitation from prescribers to prescribe Adderall. But I think all of the I think safe prescribing of stimulants, and this is one of the things that we're going to be addressing with our initiative, safe prescribing of stimulants includes risk mitigation. And so thinking carefully about ensuring that when a patient receives it, that they're receiving benefits. So doing measurement-based care, looking at symptoms and following over time. And then, so basically essentially knowing and showing that there is improvement in symptoms, and then pairing that with the different risk mitigation strategies that we've used with other controlled substances that have risk of being diverted or misused. So things like random pill counts, urine drug screens, PDMP checks, so prescription drug monitoring program checks, to ensure that people are only getting their controlled substances from one source. So I think any successful prescribing of controlled substances or substances that have risks of addiction or misuse really is about pairing it with those risk mitigation strategies. And then I see your comments on medical marijuana being used to help clients with ADHD. My comments are essentially very similar to the comments I made earlier about medical marijuana and PTSD. I don't think that medical marijuana is an effective or evidence-based approach for treatment of ADHD. So it's not something that I would endorse or that I believe we have evidence to support. So I think that, and that's pretty much going to be my statement and response to just about anything listed as a diagnosis of medical marijuana. So that is my perspective on the use of medical marijuana. It's a bit harsh and may not be what folks want to hear. I know my patients don't necessarily want to hear it, but that's the line that I stand on for now until I'm proven, until I see proof otherwise. It's convincing to me, and I haven't yet. From Jessica, has there been any difference in results in the opioid initiative between men and women? Oh, that's a great question. So first of all, the VA population is largely male. So we have overwhelmingly large male population and a very relatively much smaller female population of veterans, though our younger veterans coming out of the OEF cohort and more recent conflicts, we have a much larger female population. So the female population of veterans that are receiving treatment at VA has grown dramatically in the last 20 years. And I actually can't speak offhand to the differences in the results in our opioid safety initiative based on gender. But it's an excellent question that you raise. I don't know that I've ever seen it presented in some of our, I end up seeing a lot of our summary statistics around opioid safety because of the role I play with the psychotropic drug safety. So I'm sorry that I can't answer that for you today, Jessica, but I could reach out to some people. If you want to email me, you see my email on the slide here. You can email that question to me and I'll see if I can get the answer for you from the folks who have their hands on that data. And Elizabeth can hear 3 people talking. I think that I'm not hearing 3 people talking, but I'm not sure if other people have an open line, but thank you for letting us know. Thank you, Elizabeth. Any other final questions? I see we're kind of about to run out of time. I appreciate that you all took the time to join the call or join this session, and I hope that it has been helpful. As I just mentioned to Elizabeth, you can feel free to reach out to me by email at my VA email there on the last slide. I'm happy to talk with any of you about anything. So feel free to reach out and happy to connect you with folks at your local VAs if you have questions about the work they're doing around opioid safety or prescribing psychotropics and safe prescribing of psychotropics or academic detailing. I can make connections locally for any of the VA facilities in Pennsylvania if that would be helpful for folks.
Thank you very much. Also, we appreciate
Thank you very much. Also, we appreciate your time.
And thank you everyone for participating.
And thank you everyone for participating.
All right, well, thanks everyone. Enjoy the rest of your day.